So, sir, we are live now. We can start.
Yeah, we need 1 minute. Just say, Dr. Amin is not connecting, right? He lost connection.
Yes.
Somebody can check up on phone with him.
Yeah, I will try to contact him after. We'll give 1 minute more or 2 minutes just to. In the management event, there is one raise hand.
Yes, sir.
Okay, is it in the chat? Can you tell me who's in the chat? Okay, after we start, we will take the raise hand later on. Okay, Dr. Amin, I think now is connecting with us. Dr. Amin?
I'm here. I'm connected.
Okay. So, Assalamu alaikum. Good evening, dear colleagues and friends, wherever you are. I would like to welcome today our speakers, eminent speaker in the first episode of Master Medical Retina from A to Z. We will have a series, as you know, and we announced before that we will have about 10 series, maybe more. So it will take all the principles of medical retina from a prominent and eminent speaker in the field. And we need everyone that he need to get a training certificate. He should attend all the episode of this series of the medical retina. So some people, they like to join only uveitis. That's well and good. Some of them, they like both. So anyone can join both. But for a training, to get a training certificate, which will be signed by an eminent speaker and eligible for some point that we'll announce later on. I don't like to delay you anymore. So today we'll have with me dear friends and our, let's say, mentors that we learn a lot from him, Dr. Danish Talwar. He's a senior consultant, eye specialist and vitreoretinal surgeon, Apollo Indra Prasad Hospital, New Delhi, India, Director, Vitreoretina and Laser Service Center for Sight, New Delhi, India. Dr. Danish Talwar is a well-known figure, a vitreoretinal surgeon and medical consultant ophthalmologist. Actually, we are proud and happy that we accept our invitation and learning from his experience. And other speaker, it will be Dr. Amin Marashi, also dear friend, and he is a well-known figure in medical retina, and he's giving, even he published a book about teaching about the medical retina and especially in OCT. He's a CEO and medical retina specialist, Marashi Eye Clinic, Apollo Eye Syria. So today, and we apologize that Dr. Fahad, he have some urgent issue that he couldn't join us for today. So, and the first talk, it will be by Dr. Danish Talwar. He will give us an applied anatomy of the retina. This is, I know it could be a simple thing, but it's very important something to refresh our memory about the anatomy. So when we are going to talk about any pathology in the retina, it will be very easy to recognize where is the site, and from that you can give a hint about the diagnosis. Dr. Danish, the mic with you, please.
Yeah. Okay. So. Yeah. Can you see my presentation?
Yes, please. Just make it on slide share, please.
Yes. Okay.
Yes. Yes.
Okay. So this is the disclaimer. Now, basically, let's come straight to the anatomy of the retina. And what are the general considerations regarding this? Of course, we all know this is the innermost transparent coat of the eyeball. The three coats, the sclera, the choroid, and the retina. And this comprises 72% of the entire sphere of the eye, because it's in the posterior part of the eye. The anterior part, of course, you know, is the cornea and the ciliary body. It contains within it 7 million cones and anything between 75 million to 150 million rods, which are the photoreceptors which will actually do the sensing of the light and then transfer it to the brain. Now, the extent is all the way from the optic nerve to the ora serrata. And the thickness is minimum at the ora serrata and maximum adjacent to disc. Note this is a very important point, and I will discuss its utility. The strongest attachments of the retina to the choroid are at the ora and at the disc, and its attachments at the to the vitreous are at the ora at the vitreous base, the disc, the macula, and the retinal vessels. These are the most important areas where the vitreous has attachments to the retina. Now, the important thing is that because the thinnest part of the retina is in the periphery, so you are most likely to cause a break in the retinal periphery during manipulation. And the central retina is least likely to tear. And that is why when you do the PVD, you do it, you don't start with trying to create the PVD in the periphery. You always start near the disc and you try to create it nasal to the disc, so that that's the safest area, of course. The other important things to remember, the optic nerve at the posterior part of the eye is 1.5 millimeters in diameter, and this translates into something like 7.5 degrees of the visual field. The retinal vein diameter at the edge of the disc is 125 micron in size. Now, why is this important? These are two very important tools for measurement of any lesion. If you have, say, for example, you have hard exudates or you have drusen. Now, are they big drusen? Are they small drusen? The retinal vein diameter gives you an idea what is the size. It's a bigger lesion. The disc gives you an idea what is the size. So this is why it's important to have these measurements. At the ora, the 9 inner retinal layers convert into non-pigmented epithelium, and they fuse with the pigmented retinal epithelium. So this is from where onwards you cannot you cannot cause any further tearing. The tearing can only occur up to this layer. So where is this ora located? Now, it's important for me to know when I look at the eye, where is the ora? So where the surface anatomy, if you look at it, it is the insertion of the medial and lateral rectus. Basically, this is the insertion of the recti, which we call the spiral of Tillot's. I'll just come to that. And basically, what is a dialysis? A dialysis is a break of the retina, the 9 layers of the retina, from the non-pigment epithelium. The pigmented epithelium is constant all over. So this is a dialysis is the break of this retina at the ora serrata from the non-pigment epithelium. This is what is important to remember. This is just to show you diagrammatically the outer markings of the ora serrata. If you see, the medial rectus is 5.5 millimeters from the limbus, inferior is 6.5, lateral is 7.9, and the superior is 7.7 millimeters. So this is what is known as the spiral of Tylox, and this is along what you find the ora serrata. This is the marking of the ora serrata on the surface. Now let's come to the macula. Now the macula, if you look at it, the anatomical macula. Why is it called macula? It's called macula because macula lutea. It's got yellow pigment. It's got within it, it's got lutein and zeaxanthin. And because of that, this area from which is 5.5 millimeters in diameter is called the periphovia. And then another region under that, which is 2.5 millimeters in diameter, is the paraphobia. Now, what's the importance of the paraphobia? This has 2 to 4 layers of ganglion cells within it. All these layers, the periphobia, the paraphobia, these are centered on the foveola, the center of the fovea. And this, the anatomic macula, the periphobia is all the way from the upper to the lower temporal vascular arcades and at the disc nasally. The paraphobia has the characteristics that it has the highest number of cones, the highest density of the cones, and it has greater than 5 layers of ganglion cells. So this just to show you that diagrammatically, this is the fovea, which is 1.5 millimeters in diameter and centered at the center of the fovea or the center of the foveola. Next to that comes the paraphobia, which is 2.5 millimeters in diameter. And then you have the periphobia, which goes all the way from the arcades on both sides and up to the disc on the nasal side. Now, the important thing to remember is that the central area, the depression all the way from here, you can see from my arrow, this depression area is the fovea. And within that, the plane area is the foveola. This is around 350 microns. And you know, this angulated surface is actually called the clivus. And the center of this foveola, right, the middle part is called the umbo. We'll just come to that also. So like you see, the fovea is something like 1.5 millimeters in diameter and is centered on the foveola. This is the center of the foveola. And the important thing is that in the foveola, now if you see this central area, you see there is no ganglion cell layers here, no inner plexiform layer there, no inner nuclear layers. And the inner nuclear layer becomes approximately double at the edge of the fovea. The foveola, which is the central area, is around 350 microns in diameter. It is devoid of capillaries in the central 500 micron. In that area, there are no foveal capillaries. So it's the foveal avascular zone. And the important thing is that the central floor of this depression of the fovea centralis has the highest cones, 50 cones per 100 micrometer. And so has the highest visual acuity. And the last bit to remember is the anatomical umbo. Umbo is the precise center of the macula, which you see corresponds to that the clinical light reflex, that dot which you see. And this is 150 microns in size. Now let's come to the peripheral retina. What about the periphery? The most important thing to remember in this is the equator and the surface anatomy of the equator. If you look at it at the surface of the eyeball, it is 15 millimeters from the limbus. And if you look, now if you reflected the conjunctiva and you're looking at it, you'll see it is 3 to 4 millimeters anterior to the exit of the vortex vein. The vortex veins come out from the exit from the sclera 18 millimeters from the limbus. And these are, and in the middle, there are 3 millimeters of intrascleral pathway. And then you have the ampulla. So this is 15 millimeters from the limbus, and this is signified by the ampulla order of the vortex vein. And the vitreous base, which you see, is internally 2 millimeters anterior to the ora and up to 1 to 4 millimeters posterior to the ora. So let's have a look at that also. So if you look at this, you have the equator, which is 15 millimeters from the limbus. Exit of vortex veins is a little behind that, 18 millimeters. And this is important when you're doing your scleral buckling. And the vitreous base, if you look at this area, this is 2 millimeters approximately anterior to the ora and 1 to 4 millimeters posterior to the ora. The other important thing to remember is what is the pars plana? The pars plana is the area anterior to the ora serrata. Now, this is important because if you make a break in the pars plana, it will not cause a detachment. But if you are posterior to the ora and you make a break there, you'll get a detachment. So this is the important thing to remember. Now, if you see the margins, if you see the limbus, now at the limbus, if you see the mid-limbal line, that's the end of the blue limbal zone. From there onwards, the first 2 millimeters is the ciliary body zone. Then you have the pars plicatum, which is around 2 millimeters. And then you have the pars plana, which is a 4 millimeter zone which reaches up to the ora. The importance of this is when you are making, say, for example, if you're doing scleral fixation, you are approximately from the mid-limbal zone 3 millimeters away, 2.5 to 3 millimeters away when you make your incision, so that you don't end up causing, you're not too posterior and not too anterior. You don't want to go through the root of the iris. Now, just to show you, if you see this, the vortex vein ampulla looks like this. It's like a ribbon-like structure. You can see these ribbons joined together into this one bigger ampulla. And this is the marking of the equator. So you see over here, 2 arrows both point to the equator. So this marks out the equator for you. When you're doing laser, you know if you're doing a PRP, you want to do at least up to the equator. You actually, nowadays, we normally go anterior to the equator, but this is the minimum area that you want to cover. Now, what about the blood supply of the retina? The blood supply of the retina comes from 2 areas, from the retinal arterial vessels. So they supply to the nerve fiber layer all the way to the inner nuclear layers. The large retinal vessels are in the innermost part of the retina. And the important thing is that they have a common sheath in the initial parts. Their first 2-3 separations, they have common sheath of the retinal arterioles and the retinal veins. Now, the important thing, and either may lie above. Now, if the artery is above the vein, it can cause an occlusion of the vein. And that's how a branch retinal vein occlusion occurs. This is important in the etiopathogenesis. And that is why there was a time when we even tried sheathotomy. You separate out the artery and vein, and maybe the vein, the BRVO will open up. Now, what about the blood? One important thing, a nugget you should remember, 18% of individuals have a cilioretinal artery. This is derived from a short posterior ciliary artery, and which comes from the choroidal vasculature, enters the retina on the temporal side of the nerve, optic nerve, courses towards the fovea, and then contributes to the retinal vasculature. And in 15% of patients who have this cilioretinal artery, it supplies the macula exclusively. So if you are, if that person is one of those lucky people whose macula is supplied by the cellular retinal artery, even if he gets a CRO, he does not lose vision. So this is very important to remember. Now, the retinal vessels form 3 capillary plexuses. One is the superficial capillary plexus, and then you have the intermediate capillary plexus and the deep capillary plexus. The superficial capillary plexus is in the ganglion cell layer. The deep capillary plexus is between the outer 50% of the inner nuclear layer and the outer plexiform layer. So it's deep in. And what is the importance of this? Now, if you have a hemorrhage, you see, because the nerve fiber layer in the peripapillary area, the radial peripapillary capillaries run parallel to the nerve fiber axons. So if there's a hemorrhage there, you get a splinter hemorrhage. What do you get? It just radial to the disc. So you have those splinter hemorrhages radially. When you are inside, when you have in the rest of the retina, there the superficial, it's in the nerve fiber layer, ganglion cell layer, so you get flame-shaped hemorrhages. And when you're deeper down, then you get dot and blot hemorrhages. So the deep capillary plexus would be causing dot and blot hemorrhages. The superficial would be causing the flame-shaped hemorrhages. This is the importance of this. Let's last come to the choroid, which is thickness is around 0.22 millimeters posteriorly and around 0.1 to 1.15 millimeter anteriorly. This has attachments to the sclera, which anteriorly are tangential and posteriorly are perpendicular. So they can't posteriorly, the implication is posteriorly it cannot separate easily, anteriorly it separates much more easily. The role of the choroid is basically to dissipate heat and also to nourish the retinal pigment epithelium and the photoreceptor layers up to the inner nuclear layer. Remember, the highest rate of flow, blood flow within the eye, within the body is in the choroid. If you look at it per ml per gram per minute, it is 4 times higher than the kidney cortex. And more than 70-80% of the eye in the blood supply in the eye is going to the choroid. And what is the implication of this? That is why you get eye is a major site for choroidal metastasis. A lot of inflammations you get it in the eye. You get endogenous endophthalmitis happens in the eye. So this is why this happens. The choroid gets its blood supply from the long posterior ciliary arteries, the posterior branches, the short posterior ciliary arteries, which are anywhere between 2 to 20, which are arranged around the disc, and then the anterior ciliary arteries, the recurrent branches. And the drainage happens through the vortex vein, through the ampulla. And I've already talked about the intrascleral course. And finally, they go to the superior and inferior orbital veins. The important thing is that even the choroidal blood supply is an end artery system. It's a lobular end artery system. It's not as if they're mixing around all over the place. It's staying within the vessels. Lastly, we come to the vitreous base. The importance of the vitreous cortex is that the base of the vitreous, which is at the ora, the fibers are running perpendicular and inserting into the retina. Now, this is very important because don't ever try to separate the vitreous there. It can only be shaved off. It can never be separated out. If you cause too much traction there, I told you it's thin retina, it will cause a break. So combination of thin retina and fibers which insert into the retina means you'll get a break if you pull too hard. In the rest of the retina, the fibers of the vitreous run parallel along the posterior vitreous membrane, and so separation is possible. And when traction happens on this, that's why you get a macular hole or a vitreomacular traction. Now, why is it important for us to know all these small nuggets? The fact is that understanding of this complexity of the retinal anatomy is important for us for effective management of our retinal disorders and for planning our surgery so that it is safe. So that is why we must know about the anatomy. I've only talked about some of the very brief, very important points. There's lots of things which can be discussed whenever we want to. Thank you very much, ladies and gentlemen.
Thank you very much, Dr. Danish, for this an excellent presentation as usual. And you make it very simple also, and you make it, I know it's very long to talk. If you want to talk about anatomy, we need a lot of more than, I mean, it's a book to talk about, but several symposiums, several conferences to talk about anatomy. But we take only a highlight about a very important point that you mentioned. Maybe when we have also Dr. Amin, he will talk about the OCT and the OCTA. He can also highlight about point how we can see the different part of the retina by looking to the OCT as a method of looking to the macula or the pathology in the retina. There is only one question came to my mind when we are talking about central involvement of the macula. Do you mean only the fovea or fovea, or what does it mean when we are talking about the edema?
If we talk about vision getting involved, it is usually the fovea. That's the central 350 micron. If this central 350 micron gets involved, then you will get some scotoma at least. You get into the center, you'll get a vision loss. This is the area where in a diabetic, if you get a loss of the ISOS junction and the external limiting membrane, vision will be affected. It's a bad prognostic factor. Now, when we talk about, otherwise, when we are talking about the macula, we are talking about the area between the arcades. We are actually referring to the anatomic macula. So this includes the center involving macular disease also, and it involves non-center involving macular disease also. So
no, I mean, what my question is, when we are talking about central involving macular edema, we mean only the fovea.
Yes, we're talking of the center of the fovea.
Center
of not only then we are not even talking about the fovea. We are talking of the center of the fovea.
Yeah.
If the center of the fovea has even a little bit of fluid, then you have center involving diabetic macular edema. If that center is spared, then you have non-center involving diabetic macular edema.
So the prefovea is not part of the central.
The fovea, see, the fovea is centered on the, if you take the fovea, it's 350 micron. It's not 1 point. The center of that fovea, that is center involving diabetic macular edema. It is not the, supposing, can I just go to the diagram for a second?
The curve, yeah, we will show it in the OCT. I think it will be in that way.
So if you don't involve the center, it is not center involving macular edema. If the right and the center area is not involved, it is not center involved.
Okay. I think now the time is for to introduce Dr. Amin. And he's going to talk about the OCT and normal OCT and OCTA. Dr. Amin.
Okay. Can you see my screen now?
Yes, please.
Okay, now I'm going to talk about the OCT scans and the normal findings. There are several types of OCT scan. The one called tomography, which is a qualitative. We can see the qualitative scans, which are macular line or B scan, macular radial, macular multi or raster. Sometimes it's called mesh. And we have the topography, which are the quantitative analysis. We have the macular map and 3D, OCT infas, which is a C scan, and OCT angiography, which we will talk today about its normal findings. The line will show, we have always in the OCT report, we have this image, could be infrared or SLO. Here, an example of an infrared image. We can see this red arrow, which depicts the direction of the scan, or where the scan it follows this arrow and the direction of the arrow. And as you see, there is a red spot, a yellow spot, sorry, which shows the area of this vertical a yellow line that show us the precise location of the yellow indicator on the SLO or infrared image, where it's located on the OCT cross section. And we have this graph which shows us the variation of thickness changes. So the OCT machine software can help us to see those variation of thickness in which layers, for example, this between the ILM and the RPE Brooks membrane complex, we can choose, for example, the inner nuclear layer and the outer plexiform layer, and we can study the variation of thickness. In contrast, the macular radial is a multiple line scans where the center of each scan is at the center of the fovea, and they are those line scans are crossing each others and forming in a form of 12 or 6, depends on the software capabilities. We can stretch those lines or minimize their length. We can move all this radial scan. This depends on the software itself. The OCT machine, they usually generate this report, which show us every line scan, the cross section at every line scan. It can, and we can choose the enlarged or enhanced image of the most cross section that can show us the pathology. Therefore, it is very important to not to rely on the technician to find the most prominent image, because they might think it is the most attractive one. In contrast, the physician will show the most significant one. So always, if you have an OCT machine and you have referrals, the physician always should check for the best for the most significant image. Some machines can generate those topographic images of the topographic map showing this thickness map, the variation of changes in thickness inside of those radial scans, and the graph that serve the same purpose as mentioned earlier. The raster scan is a multiple horizontal or vertical image lines parallel to each others that covers an area of this areas of the macula. Those lines can be manually spaced, change the space between each other and their lengths and direction. And as mentioned earlier, the same principle applies for choosing the image and the graph. The multi or the cross or the mesh, we usually is a multiple raster scans that are perpendicular to each other, and that it can help us now to see both the vertical and the horizontal
Dr. Amin? Dr. Amin? Hello?
Sir, I guess he has lost his connection.
Maybe connection have some problem.
He is still connected with us, but I guess he's in the reconnecting mode.
You'll have to inform him then, no? He may be thinking he's doing his lecture.
No,
No, I
he's been
think-
disconnected.
Yeah. Okay, maybe within a few seconds, because maybe some electrical problem, I know, in his area. I think if we cannot get Dr. Amin, we can move to you, Dr. Danish, to give the topic of the ICG or fluorescein. It's okay, Dr. Danish. So till he came back. I think he is coming back. Yeah, he's saying he sent me a message. He is now connecting. I think we better, maybe we can move with you, Dr. Danish, then if he have, then he can continue at the end. Sorry for that. He's having some sort of a problem with internet. So if you can go off with you, Dr. Danish.
Should I, can I do both? Oh, he's
Yes,
come.
yeah, yes, please.
This is somebody else's slides. Okay. No, so I wanted to know there were two topics, no, ICG and autofluorescence. Should I do them
Yes.
together?
Yeah, okay. He's came back.
Has he come back? Should I take it off?
Dr. Amin, you will.
There?
Yeah,
Can you stop
yes.
Okay, so I'm stopping.
Yes,
I'll stop the sharing. Okay, go ahead.
Can you share this here? Screen, please.
okay. Can you see my screen?
No, you didn't share a screen. It's only your photo now. Share a screen, please. Dr. Amin? Can you hear me, Dr. Amin?
Have we lost him again?
I don't know. Dr. Amin, can you hear us? Okay. I think, Dr. Danish, we will lose time by this. Let us move with your, and if you couldn't do it today, we can do it in the next episode to be proper connections. So let's do today, ICG, normal ICG and autofluorescence.
Oh, sorry, he started sharing.
Dr. Amin, can you hear me first?
Yes, I can hear you. Can you see my screen?
Yeah, go ahead.
Yes. Okay, go ahead. Okay.
So-
if we can go fast, other okay, little bit. Okay.
Okay.
And no,
So,
not much. I mean, okay.
Okay. As I said, the raster scan is very great tool to examine the non-central macular changes. What the multi-scan is good in, or cross-scan is good for examining the central macular changes. So we should rely, on both, so we do not skip any macular changes. However, the radial scan unfortunately can skip a non-central macular lesion between the radial line scans. So the topography or macular map is a volumetric raster scan that taking scans vertical and horizontal, generating a volumetric scan. But the computer software will generate this topographic map, which is color coded, depends on the the thickness of the macula. For example, the green color is about thickness about 300 to 400, and the yellow is about 400 to 500, and the red, the yellow is 400, and the red is between 400 and 500 thickness, while the white is above 500, and the 200 and below is the blue color. However, the topographic map it is dependent on the software and the information input. For example, it will be affected on the sex, on the age, on the pathology, and the race. For example, as I live in Syria, there are only few machines that supports Arab race. We have to rely on the appearance of the patient to put a Caucasian or Latin. So we cannot get an accurate results about the topographic map, and especially if the technician is not putting an accurate information about the patient. So those topographic maps may be not accurate. So, for example, it can gives us a false information about non-central macular edema, and in fact, on the tomography, we can see there is a central involvement of the macula. So always rely on the tomography in order to depict the precise location of the pathology, and not on the topography itself. Another thing, as you see in the topography, there is those 9-sector ETDR's 9-sector, which is which shows us the thickness and in number and in volume in of the ETDRS circle. It is very important to study the number, which it takes the median number inside every sector. But the coloration could be not accurate as it study the mean deviation from the data, population data inside the supplied in the software. For example, this is a totally normal retina, but we can see there is a variation in red and yellow color that could be due to inaccurate input of the patient data. The volumetric scan is very important to show us the whole macular in cube in scanning from the superior to the inferior aspect of the macula, which is very important to show us the vitreomacular posterior cortical hyaloid adhesion, which is very important to depict if there is a posterior vitreous detachment before going to the surgery, and to locate any pathology that we can miss in the radial and raster scans. The 3D is it serves as it serves an importance when demonstrating the pathology to the patient, as we can show him those variation of colors and the elevations to show him the pre and post treatment, and sometimes those 3D topographic maps can help us when we want to do parasplanate vitrectomy to depict the precise location of the vitreomacular adhesion. The most spectral domain and swept source OCT machines can supply us with an in-fast OCT, which is called C-scan. The C-scan is very a multiple B scans are that rendered in 3D volumetric data that we can slice those frontal scans into each layer. For example, here we have the ILM slab, and we have the inner plexiform internuclear layer slab, and we have the RPE Brooks membrane slab, and we have the choroidal slab. This holds a very important when we want to study the pathological findings in each layer, and that thus helps us to for example, if we have a diabetic macular edema and we can easily miss the presence of epiretinal membrane. So the ILM slab will isolate this epiretinal membrane from the other findings. We can depict if there are any RPE changes and etc. The normal findings or the normal findings of the OCT and retinal structures are the following. First, we can visualize the vitreous. We can see there are a hyporeflectivity, which inside this moderate or mild reflectivity of the vitreous, which is the vitreous synoraces. We can see the posterior cortical hyaloid, which is very important to study the retromacular abnormalities. We see the retrohyaloid space, and the retinal nerve fiber layer is presented as a thickened hyperreflective layer that is more that has more thickening in the nasal aspect than the temporal aspect, and we have more hyporeflective layer, which is the ganglion cell layer, and then again a increased reflectivity layer is the inner plexiform layer. By the way, the retinal nerve fiber layer, the ganglion cell layer, and the inner plexiform layer forms what is called the ganglion cell complex, which is very important when evaluating the glaucoma patients. After that, we have a very important layer, which is the inner nuclear layer that presents anatomically the end of the retinal vessels. And then we have the outer plexiform layer, which appears as a hyperreflective layer. And then we have this outer nuclear layer, which is thick at the fovea and becomes thinner as we go to the periphery. Then now we're gonna present the outer retinal layers, which we have this hyperreflective thin line, which is the external limiting membrane. Then we have this myoid zone, which is a hyporeflective band between the external limiting membrane and the ellipsoid zone. The myoid zone itself presents the inner segments of the photoreceptors, where the ellipsoid zone presents the outer segments, inner segment junction, which is called ellipsoid zone at the center of the macula, while out of the center of the macula and the outer is called the ISOS junction. After that, we have the outer segment layer, which only prominent at the center of the fovea, and has and exhibits a hyporeflectivity. Then we have the interdigitation zone, which presents the outer segments tips. It's not always visible. If we cannot see it, it is not doesn't mean pathology. It's not, it isn't always visible in spectral domain OCT. And we have the retinal pigment epithelium, and after that we have the choriocapillaris, which is a very thin layer. Then we have the Sattler's layer, which contains the medium-sized choroidal vessels, and we have the Haller's layer, which contains the larger choroidal vessels, and then we have the sclera. Sometimes we can observe the suprachoroidal space, but is not always visible in spectral domain OCT, and it is more visible in swept source OCT. We usually use the negative gray-white white to gray, sorry, picture in order to differentiate between the hyper-reflective layers and hyporeflective layers. For example, if we had a doubt of any layer that has which contains increased reflectivity, we always can switch to negative, and we can observe the changes at those layers. We have the pseudo color. The pseudo color, which shows the colors depending on the reflectivity. The more reflective, the more red. The less reflective is in blue, but the easier reflective is in green. But as you notice, it is not accurately cannot accurately depict the layers boundaries as in black and white. So when examining OCT cross-section, the vitreous always vitreous changes along with its relation to the inner retinal tissue should be evaluated. Assessing of retinal contour and integrity of the retinal tissues and ellipsoid along with the integrity of the RPE and underlying choroid should be evaluated. It is essential to assess the changes in retinal thickening and changes in retinal tissue reflectivity. Okay, so now I'm gonna move to the OCT angiography scans and its normal findings. OCT angiography is a non-invasive method that generate 3D slabs to evaluate the retinal and choroidal vascular changes, which has advantages over traditional methods such as fundus fluorescein angiography, but do not replace it. The software can automatically produce 4 slabs assessing vascular changes at different levels. However, the software allows manual segmentation. Thus, OCT angiography has several clinical applications ranging from retinal vascular disease to Brooks membrane choroidal vasculopathy diseases. OCT angiography interpretation needs a learning curve and attention to correlate its findings with OCT cross-section structural influence OCT and possible artifacts. So the principles of OCT in a nutshell: the OCT will register scans for the same area multiple times, 2, 3, 4, or more, depends on the machine and software protocol, with a brisk time-lapse registration, which is called intrascan time, covering 2 volumetric scans, 3x3, 6x6, 8x8 millimeters or more, depends on software. Hence, when the signal is reflected, the retinal tissue is static tissue that will remain the same at the same time. The dynamic blood flow of the vessel will change between scans, generating what is termed decorrelation signal. The software will register changes in blood cells flow, forming OCT angiogram or decorrelation map that render the representation of the vascular network. So the shorter interscan time helps to capture fast-moving blood cells, while longer interscan time will allow slow-moving blood cell. Adjustment of interscan time will lead to interesting OCT angiograms, but unfortunately, this is not allowed in commercial available machines. OCT angiography is available in spectral domain and swept source OCT machines. The main difference is wavelengths, and the former is about 840 nanometers, and the latter is about 1050 nanometers, which provides better penetration and better choroidal imaging. The main difference between OCT angiography and fundus fluorescein angiography that the latter is an invasive method that requires dye injection that can produce potential complications ranging from mild nausea, vomiting, to an allergic reaction, and sometimes anaphylactic shock, even death in 1 in each 200,000 cases. Thus, fundus fluorescein angiography should be done in a facility with an emergency plan in situ. Fundus fluorescein angiography is a two-dimensional image, 45-degree or more. Fundus fluorescein angiography show only the perfusion status of this superficial capillary plexus and won't be helpful to evaluate deep capillary plexus. Fundus fluorescein angiography show leakage from microaneurysms, leakage pattern, and cases of central serous chorioretinopathy. Can show us if there is an active neovascularization and can show us the leakage and the pooling from microneovascularization and pooling from subretinal dye pooling. In contrast, the OCT angiography is the three-dimensional image, non-invasive, and does not require any dye injection. Hence, it has no complications and can be repeated as much as needed. It can clearly show the vascular anatomy changes in the deep capillary plexus. However, OCT angiography can be time-consuming and needs cooperative patients with a limited field of view in most OCT angiography machines. However, software can stitch multiple scans. Other drawbacks of the OCT angiography is missing areas of slow flows, such as cases of microaneurysms or fibrotic macular neovascularization, not providing information about vascular filling or transit time, and potential artifact. This problems are being overcome with the newer machines with faster scan acquisitions. Nevertheless, OCT angiography won't show any leakage, which can be handfully evaluating vascular changes without being hindered by leakage. For example, as presented here, OCT angiography can provide precise measurements and changes of foveal avascular zones, such as vascular network interruption and a difference in vascular level and vascular network blood flow of macular neovascularization. As here we can see, there is a macular, there we have a fibrovascular pigment epithelial detachment, and here we have the decorrelation signal depicts the blood flow, and we can clearly see the a neovascular network in both outer retina and peripheral capillaries slab. OCT won't show the sign of hard disk and flower petal in macular leakage in pseudophakic cystoid macular edema. Therefore, fundus fluorescein angiography still plays a significant role differentiating between pseudophakic cystoid macular edema and diabetic macular edema in diabetic patients suffering from cystoid macular edema. So, OCT angiography won't replace fundus fluorescein angiography, at least for now, and still the fundus fluorescein angiography plays a significant role in diagnosing and planning treatment in specific macular pathologies. One of OCT angiography limitation is that the different machines have a different protocols. Hence, different machines may capture the different blood flows. The same machine should be used to obtain accurate OCT angiogram between follow-ups to have an optimum follow-up. Another limitation is scan density, as when using 3 by 3 millimeters are obtained, the scan density is higher and can detect fine vessels. In contrast, 6 by 6 scans can miss fine vessels, which might generally false vascular dropout. It is imperative to have the same machine with the same scan size between follow-ups. Let me now discuss the normal findings of each scan. The superficial capillary plexus contain vascular network from the ILM and 15 microns below the inner plexiform layer. The in-face OCT angiogram will show retinal
Mr.
vascular
Amin, we
anatomical
lost
structure.
connection for a few seconds. Okay.
Am I back now?
Yeah, okay.
Can you
Yeah,
hear me?
okay. Yeah.
Okay, so let me repeat. The superficial capillary plexus contains a vascular network from the intralimiting membrane and 15 microns below the inner plexiform layer, as seen here, as depicted here. And The INFAS OCT angiogram will show retinal vascular anatomical structure with a central foveal avascular zone, and will show a web of regular and homogeneous vessels converging towards the foveal avascular zone and originating from the large retinal vascular arteries. Simulates what we see in fundus fluorescein angiography. So when examining the superficial capillary plexus, it is important to rule out microvascular changes such as capillary non-perfusion, increased vascular spaces, decreased vascular density, enlargement of foveal avascular zone, and new vascularization. The deep capillary plexus contains a vascular network from the outer boundaries of the outer plexiform layer with a total thickness of, from the outer boundaries of the inner plexiform layer and the outer boundaries of the outer plexiform layer. So the deep capillary plexus is this area of vessels are captured, and it is a total thickness about 55 microns. It is usually depict the configuration of the closed net with a central foveal avascular zone. When examining deep capillary plexus, we should rule out verification, budding, increased intracapillary spaces, decrease in vascular density, non-perfusion, vascular dilatation, and changes to foveal avascular zone. This layer is poorly seen in fundus fluorescein angiography, but seen clearly in OCT angiography, which gives the OCT angiography advantage over the fundus fluorescein angiography, which may show early and subtle changes in diabetic retinopathy, retinal vein occlusion, paracentral acute middle maculopathy, macular telangiectasia type 2, and macular neovascularization type 3. Care must be taken not to confound projection artifact from the superficial capillary plexus, as some software can automatically remove this artifact for better interpretation. Both superficial capillary plexus and deep capillary plexus are connected by interconnection anastomosis. Both layers can accurately determine the size and changes to the foveal avascular zone and determine the exact boundaries and depths. Foveal avascular zone appear as a
Dr. Amin, can we
What?
Can we come to the conclusion, because we are already running in more 15 minutes than what is located for this?
Okay. So the foveal avascular
only
zone.
the highlight about the most important things about OCTA, how it looks normally in the superficial, in deep plexus, unlike this one, as soon as possible, please.
Oh, okay. So the OCT angiography advantages over the fundus fluorescein angiography is the absence of leakage. So we can visualize the vascular changes more accurately. It can provide the quantitative analysis, so we can measure the foveal avascular zone. And the foveal avascular zone here, we have two measurements. We have for the deep capillary plexus and the superficial capillary plexus, and we can see the outer retina, which is a black, appears as a black image, but in the light of presenting any abnormal vascular networks, we can visualize it. And we have the choriocapillary slab that can show us a flow deficit, or it can show us new vascularization, and it can be affected by artifacts. This is what, if I'm gonna jump into conclusions. But another thing that we always can do manual segmentation in order to study our pathology by correlating it to the B-scan overlay and to the structural INFAS OCT. So that's all.
Thank you very much, Dr. Amin, for this excellent presentation. I know it's need more time maybe to highlight all the points, but our aim just to pass through, a simple points that we need everyone to know about the normal
Okay.
how it looks like the OCT and OCTA. Thank you very much. It was an excellent, as usual. I know there is some problem of internet. We are sorry for all our attendees. I'm sorry for you, Dr. Amin, for having this problem, but inshallah it will be okay. Lastly, it was very nice done. So we can move, if there is any questions, I have one question. Could we measure accurate in number the choroidal thickness for follow-up in case, for example, in Bocchianide Harada, and does OCT or OCTA superior to ICG in case of choroiditis follow-up? We didn't go to the ACG, but Dr. Amin, if you can give within 30-second the answer for that.
Okay, yes, of course. Yes, if we used EDI in his depth imaging or swept source OCT, yes, we can do an accurate choroidal thickness measurements. And about uveitis, no, the ICG is better for diagnosis, and OCT angio is not conclusive yet for those.
Thank you very much, Dr. Amin. So we can now move to next talks by Dr. Danish. He will give a talk about autofluorescence, I think, and ICG, right?
Yeah. So,
okay.
Thank you, Dr. Anvi. Can you see my screen?
Yes, please.
Okay. So normally one talks about fundus fluorescein angiography and optical coherence tomography. But the fact is that are these two tests adequate for characterization of retinal and choroidal lesions, for diagnosis, for treatment, for follow-up, for prognostication? In fact, you asked the question and answered it partly yourself also. What about fundus fluorescein angiography? Is it enough? Well, we know it cannot view through blood. You cannot have visualization of choroidal pathology. It doesn't visualize it well. And it has a very poor delineation of occult choroidal neovascularization, especially RPE detachments. What about OCT? Is this enough? Well, no. Again, it cannot delineate the vessels, normal or abnormal. It cannot delineate areas without perfusion. So what are the tests we have? And in those, indocyanine green angiography is one of the important tests. Indocyanine green absorbs light in the near infrared range of 790 to 805 nanometer. And the emission ranges from 770 to 880, but peaks at around 835 nanometer. So because of this, it's able to do enhanced imaging of the choroidal vasculature, the choroidal neovascularization, and pigment epithelial detachments. Because basically, ICG is 98% protein bound in vivo. 80% of the ICG molecules bind to globulins, such as A1 lipoprotein. And previously, it was thought that it binds to albumin. That's not true. And so very little dye escapes from the fenestrated choroidal vasculature. Visualization of the dye is possible through overlying melanin and xanthophyll. Visualization of dye is also to some extent visible through serosanguinous fluid or a shallow hemorrhage or some pigment and a lipid exudate. That makes it important for us. The basic features, again, like in fluorescein angiography, you look for hypocynescence or hypercynescence. And some people use the term hypofluorescence and hyperfluorescence even for the increase and decrease in reflective in the light which is being emitted, even for ICG. So technically you can use the time if you have less light being emitted as compared to what you expect normally as hypocynescence, or you can even call it hypofluorescence. Both are being used nowadays. And if you have more light than should be there, it is hypercynescence or hyperfluorescence. Now, when would hypocynescence occur? Hypocynescence can occur if there's a relative block. And how can you have a block? Well, it's a relative block, either by pigment, or if it's a very large amount of blood, or if it's some serous fluid, or it's exudate. You can also get a relative block if there's decreased perfusion. The basic principles are like fluorescein angiography only. Or if there's a block in the blood flow, or there's a loss of vascularization. And hypersynescence can occur if there is an RPE dropout, so the pigment goes away. So you have, it can, through that, the light can come through. Or you can have a leakage from the retinal and choroidal vessels with staining of those areas. Or you can have some leakage occurring. So it's very little that leaks out, but very slowly from abnormal areas it will leak out, as in the case of a choroidal neovascularization or a polyp, and we call it a plaque or a hotspot. Just to show you some pictures regarding what is normal and what is the abnormality that you see. On the right side of the screen, you see a fluorescein angiogram. On the left side of the screen, you see an ICG. And if you see the ICG, you see, if you can see my arrow, you see that there's a large area here where there is a shadow kind of a hypofluorescence coming. So there's a hypofluorescence coming. This is a block with blood. You can see a picture over a black and white picture shows a subretinal bleed, and you can see that this is a block by blood. And if you see through that, there is one focal area where there is hypersynescence. It's more, this is an abnormal increased light being emitted from there, and this is a hypersynescence. It's visible through this blood. So this is the important thing here. This is another patient where, again, you see on the right side, you have the fluorescein. There's an RPE detachment. And if you see the ICG, you see that there is hyposynescence here. And then you see in the central area, you see this hypersynescence because of these polyps in this area. Now, when would you like to do endocyanine angiography? Well, we use it for, most importantly, it's being used nowadays for polypoidal choroidal vasculopathy. It is being used to document type 1 choroidal neovascularization, can be used to identify feeder vessels in a neovascular AMD, for choroidal tumors, for chronic central serous retinopathy, and in patients with posterior uveitis like MUDES or AMPP or VKH. So these are some of the conditions where it is used. Now somebody may ask that if it is, if it is such an important thing, has so much available to it, why has it not become popular? The fact is, the reason for that was lack of technology sufficiently sensitive to capture good quality images, and the exorbitant cost of this technology when it became available. 20 years back, I remember it was the machine, first machine we got was costing something like 55 lakhs, 5.5 million rupees, which you would translate into something like $100,000 at that time. Now, anyway, so there are two types of cameras available. One is called the fundus-based cameras, like Topcon and Zeiss. This is what you see over here. And you can see the quality is not so good. You can't see the vessels very well. You don't see the detail much. But then you have this Heidelberg-based system, the SLO-based systems, the scanning laser ophthalmoscopy-based systems like Heidelberg, and you see the great detail that you can see of the blood vessels. And this has made ICG a popular technique. Now in ARMD, ICG is only needed when you have occult CNVMs and can help you to differentiate PCV from occult CNVM. Just to show you some very quickly, I'll just go through this. This is a patient where you had a fluorescein angiography showing a stippled RPE detachment. And when you do the ICG, you see there's nothing in the early phase, no polyp, but in the late phase, you see this plaque has formed over here. So this is a type 1 CNVM in this patient. So ICG may help you to detect a well-defined CNV in more than half the cases of occult CNVM on FFA. And it can also help you to find a non-subfoveal location. That means amenable to laser in some 10 to 15% of patients. For PCV, which may constitute 20 to 40% of all cases of occult CNVM, ICG is needed to establish the diagnosis. It's still the gold standard, and it can also have a role in evaluating the response to treatment. Just to show you over here, this clinically looks a lot of exudation, orangish lesion, looks like a PCV. Late leakage from an unknown source, not clear. And you see this is a peaked RPD, a double layer sign suggestive of PCV. And then when you do the ICG, you find these polyps in this lesion. You find the branching vascular network. And then when you look in the late phase, this not only has polyps, it also has a plaque lesion. So what did it turn out to be? It turned out to be more. It turned out to be a combination of PCV and it had developed a type 1 occult CNV, which could be seen on an OCT angio. Now, this is another patient where you can see on PCV, on ICG, you can see the polyps, and these polyps stand out along with early phase, showing a little bit of the branching vascular network. Now, the other thing it can show you is a quiescence of a polyp. So what do you see over here? These were the polyps. With treatment, you can see one of these polyps has gone already, and in 2018, all the polyps had dissolved. So it can help you, ICG can help you to follow up whether your lesions have resolved. Now, in chronic CSCR patients, it can show you that there is a sick RP. You see the extent of sick RP on a CNVM, on a ICG, which you can pick up more easily, and you know that you're dealing with a chronic this stage of the disease. And lastly, this choroidal hemangioma, where you can see in increasing hypersenescence, and then it's washout in the late phase. So you can make a diagnosis. Otherwise, I initially, in fact, had once made a mistake in one such case of a granuloma. But this is different from a granuloma. So these are some of the things. This is the patient whom I mistook for a granuloma. You can see early phase, it starts filling up, becomes more and more intense, and then washes out in the late phase. So you know you're dealing with a choroidal hemangioma. These are the important things as far as ICG is concerned. Of course, I think you have a full session on the abnormalities in ICG. So I just pointed out basics of ICG and what abnormalities are there. As far as autofluorescence is concerned, there's a resurgence occurring. This is not detected on a conventional FFA machine. It requires an attachment to the conventional fundus cameras, or it can be a part of a Heidelberg viewing system. Autofluorescence was first described by Delori in the 80s. It's a non-invasive technique which detects fluorophores, which are naturally occurring molecules that absorb and emit light of a specific wavelength. Now, what you see over here is lipofuscin, which is an important fluorophore which absorbs light and then emits it, and then comes back to its ground level. So this happens with the light which is being used to simulate, and this is what autofluorescence then comes. Now, autofluorescence is not just from lipofuscin, it can come from a substance called A2E, it can happen from melanin, it can happen from rhodopsin. So a lot of things can cause autofluorescence. Whittley-formed lesions consist of extracellular fluorophores. This is very important. They shed outer segment debris in the subretinal space, which accumulates due to RPE dysfunction, and this can be picked up as autofluorescence. Optic disc drusen again have extracellular mitochondria in a filamentous protein matrix, and these can produce increased fundus autofluorescence. Now, this is a normal autofluorescence. This is the way normally the eye looks like, and it's different depending on the kind of filter you have. This is a Spade filter. This is with a confocal SLO like you see in a Heidelberg systems. So you can pick up these are otherwise darker. Now let's see what happens in some of the common conditions. Sorry. Now basically you can have increased lipofuscin at the edge of an RP tear. You can have subretinal autofluorescence material in vitiliform degeneration. You can have window defects or because of CSR or white dot syndromes. So there are many causes for hyperautofluorescence. Similarly, you can have because of RP atrophy or because of the photoreceptors being abnormal, you can have a reduction in the visual cycle, and then you can get a decrease in the autofluorescence, and you can also get a decrease in autofluorescence if there is a subretinal hemorrhage or a fibrosis. Now, in clinical practice, you can have three things. You can either have hyper, auto, or iso or hypoautofluorescence. Now you see over here, this is hyper, this is more fluorescence than expected, and this is hypo. So this is less than expected. Now you see over here in a patient with geographic atrophy, you see over here the central area is showing a hypoautofluorescence, and very easily to see how dense it is, and you can figure out how the vision correlates with this. This is another patient with geographic atrophy. Now you can see actually, sorry, over here the density of the hypoautofluorescence is less. It's much more in this central area, and so you know that this is becoming worsening. You can follow it up over time. And if you see the picture, you can see this is the area where the RP photoreceptor complex is getting affected. This is a patient where you can again see in an AMD patient, you can see autofluorescence, the hypoautofluorescence occurring in this patient. This is a patient where you have a choroiditis. Now, if you have a choroiditis, you can monitor the choroiditis. You can see the healed patches become hypofluorescent. Those which are healing are actually hyperfluorescent, like you see here. These are not completely healed. And then you have, look at this. You see within this, the disc was supposed to be hypo, but this is hyper. This is because of optic nerve drusen, one of the easiest ways to pick up optic nerve disc drusen. This is a patient with CSR. You can see how much clinically it looks is not too bad, but otherwise you can see this is a sick RP, and this shows up as hyperautofluorescence. This is a patient in whom Stargardt's disease is there. The central area of geographic atrophy shows up as hypoautofluorescence, and the flecks all around, they show up as hyperautofluorescence, a characteristic picture of Stargardt's, easy to diagnose based on autofluorescence. This is adult vitiliform degeneration. One eye has developed geographic atrophy. The other area you can see in the area where there's this vitiliform material, it shows up as hyperfluorescence. And this is a very clear diagnosis can be made. Otherwise, you can make a mistake of thinking this is a CNVN. This is another patient, and here it's more subtle. But if you see the autofluorescence, you can pick up this hyperautofluorescent material, and you can make a diagnosis easily. Similarly, this is a patient of bullseye maculopathy. The severity can be followed up with autofluorescence. This is a patient with serpiginous choroiditis, and I told you areas which heal completely would be hypofluorescent. Areas which are healing would be hyperautofluorescence. Now, if you have a patient who's got choroiditis, now if it is hypo, you know it's healed. But if you see an area which was hypo and now is developing a hyperautofluorescent area, it means this patient is going into activity, and this patient needs to be looked into from the point of view of treatment. Like you can see here also, these are patches which, based on autofluorescence, you cannot say they are active or not, but you can say they are not completely healed. To say whether they are still active or not, you would need to do a fluorescein angiography. So, ladies and gentlemen, these are some of the conditions which you can figure out with autofluorescence. It's a very quick way of monitoring. These are just some more patients. Autofluorescence provides a lot of information on the metabolic state and overall health of the RPE and indirectly of the photoreceptor layer. It is still evolving. It may help us to replace more invasive procedures. The important thing is, ladies and gentlemen, that by combining autofluorescence with ICG along with the conventional techniques of fundus fluorescein angiography and OCT, we can significantly improve our diagnostic ability and our ability to treat our patients more effectively. Thank you very much, ladies and gentlemen.
Thank you very much, Dr. Danish. This is an excellent presentation. You know, I know you make it only within 1 hour, so nobody knows that you prepare it very fast, but it's really amazing. Thanks a lot for this information and highlight all the points. And I want just to tell that we are going to have also another episode. It will be about the abnormality in cases of autofluorescence in fluorescein angiography, OCT, and OCTA. There is a question, I don't know this one, I think for you, Doctor, you can also answer this one. What about adaptive optics in OCT? Is it useful and helpful? Dr. Danish, also, if you can answer that.
Frankly speaking, no, I'm not quite sure about the answer. So,
okay, Doctor, we can move it to Dr. Amin. Is here Dr. Amin?
Yes, I'm here.
Okay, there is one question. What about adaptive optics in OCT? Is it useful and helpful?
I don't know about the adaptive optics. I cannot understand the meaning, what he means by adaptive optics for OCT.
Okay, I can ask Ashraf, Dr. Ashraf, I think if you can just highlight what do you mean by this question, because even me, I didn't understand. We have also here, I'm happy that Dr. Majdi Musa here in board and Dr. Hassan Al-Dibi. So Dr. Majdi, if you understand the question and you want to participate with us in answering these questions. Dr. Majdi and Dr. Hassan. You are muted, Dr. Majdi. Dr. Majdi, we can hear you.
Yes, adaptive optics, it's a new technology, which is a very high resolution OCT, which can reach up to 1 micron in resolution. But it's only working on the photoreceptor layer only to see how much affection of the photoreceptor, because it gets like a on-fuzz image of the photoreceptor layer. But again, it is not in the clinical practice yet. It is only research work using adaptive optics because it is not in the market. I mean, we don't have machines. You can buy a machine with adaptive optics up till now. It's only prototypes, and it's in the research centers working on very fine details up to 1 micron in the photoreceptor and outer retinal layers. But it is not in the market and not helpful yet.
I hope you are not driving, Doctor.
I am not driving. I am in the car, but I'm not driving.
Okay. I'm very happy and glad that you are with us, actually. Dr. Hassan, we need, if there is any comment or question about what we have moved about the OCT.
I do agree with Dr. Majdi about adaptive optics. It is starting maybe 7 to 8 years from now. And at that time, it's based on the photoreceptors, morphology and how it's affected by certain and different diseases. But to read this and to look for it, how it is affected, it's not established. So it was for academic purpose and under research, but it's not used in the field of diagnostic or even monitoring by the time being.
I think I didn't hear about it really, Dr. Hassan, to be honest. I think also other colleagues here, so that we couldn't figure out what is the main of the question. Thank you for the clarification. Is there any comment from you, Dr. Hassan, about what we have mentioned about autofluorescence, about fundus fluorescein angiography? Today we are actually talking about the basic things that we need to know in OCT. So we know the anatomy first of all, to be sure what is the pathology, where is the pathology. I think Dr. Danish was explaining it in an excellent way in a very short period about the anatomy. Dr. Amin also, he was explaining a lot about OCT and OCTA. I know we cannot cover everything. Our aim is just to highlight about the points. And I will ask all our colleagues also, this episode, it's available in the YouTube. It's called Myom Academy YouTube channel, so you can hear or listen to this lecture. Maybe then you can, in a slow way, or you can understand all the points that they mentioned, either by Dr. Danish or Dr. Amin. I don't know, Dr. Amin, I think there is one topics, but I think we are already behind the time, so we can keep it to the next episode, if you allow me for that.
No problem.
Is there any question from our colleagues or any comment, Dr. Majdi, Dr. Hassan, Dr. Danish, Dr. Amin, before we conclude these sessions? I hope that everyone enjoy, as I enjoy, and I learn a lot from everyone.
Yeah, I joined a bit late, but really I enjoyed to listening to Dr. Danish. He was really giving things, two big topics in short and very nice way. And he really mentioned most of the important indications for either ICG or autofluorescent, which we need to be aware about as retina specialists. Actually, it was great with the clinical cases, which is really giving the most important part to how to use this multimodal imaging to help in diagnosis, especially in BCC, and then to use it in monitoring as well in the posterior multifocal choroiditis or serpiginous line. So it was great in short times and really very educational, informative.
Thank you very much, Dr. Hassan. Dr. Majdi?
Dr. Muhammad, I also joined a little bit late because you see I'm traveling, but anyhow, I really enjoyed the part I've seen, and it's the basic knowledge. It's very important to connect the basic knowledge with anatomy with the clinical practice, like I've seen in the last lecture. This is our aim, to connect what we see anatomically with what we find clinically. This is a very good application, as we spoke, me and you together before. It's a clinical application through knowing the basic knowledge. Thank you for all the presenters, and I wish that the next episodes will be more and more informative. Thank you.
Yes, actually, we are going to build on what we are learned today in anatomy or normal OCT, OCTA, fundus fluorescein angiography, autofluorescent ICG. And later on, we'll talk about the abnormal, then we'll go to the diseases. So from this one, we can get, a great idea or a knowledge about the retina, medical retina. So we have to master all the information that we are getting. And I would like to thank you also, Dr. Amin. He's done a great job. He was explained, I learned a lot. So many points he highlight in OCT. Thank you, Dr. Amin. Dr. Danish, thank you very much for your time. I know it's too late for you, but we are happy that you are with us. Also, Dr. Amin. Dr. Majdi, thank you for coming with us. Dr. Hassan, thanks a lot for attending with us also and participate in the panel. And your comments is a very important add value to our meetings. Actually, we will just announce that there will be a link for feedback, and also if someone will also want to get a certificate of attendance, but certificate of training, as we mentioned earlier, it will be at the end of each series for each, one training for each different type of series, either medical retina, uveitis, or as we mentioned, refractive. Our next, it will be in the beginning of April. Maybe it will be one day before Ramadan, so it will be on the same timing. After that, we are just waiting for the feedback to change our timing according to the feedback that we will receive from all our attendees. Thank you very much. Thank you for the management event, and have a nice and good evening and night, and good night all. Thank you very much.
Good night, everybody. Thank you very much.
Bye-bye. Thank you very much, Dr. Danish, Dr. Amin, Dr. Hassan, and Dr. Majdi. Bye-bye.
Thank you.
For dear colleagues, attendees, they can please, before you leave the meetings, please try to download your certificate of attendance. Thank you very much, and bye-bye.